There's this pill sitting in millions of medicine cabinets right now, like maybe even yours.
Oh, almost certainly. It's everywhere.
Right. And it costs literally pennies. I mean, it affects over 1 billion people worldwide. And honestly, it fundamentally changed human life expectancy. But if you look closely at the chemistry...
Which we definitely did for this deep dive.
Yeah, exactly. If you actually look at the pharmacology notes and the medical history we pulled for this, it shouldn't really work the way we think it does. In fact, on paper, it looks like it could be dangerous.
It's the ultimate quiet giant of pharmacology. We are talking about a drug class so ubiquitous it is practically invisible to the people who swallow it every single morning.
Totally. Looking through the source material today, I was just blown away by the sheer amount of mystery surrounding this tiny pill. So for you listening, today we are pulling back the curtain on Thiazide Diuretics.
Yeah, it's a wild story.
It really is. We are going to figure out how a failed experiment from the 1950s accidentally became a medical miracle. We'll, map out how it physically alters your kidneys, untangle its bizarrely paradoxical side effects.
Because there are a lot of them.
Oh, so many. And we'll see how a cheap generic managed to defeat the pharmaceutical industry's most expensive modern inventions. Okay, let's unpack this.
Yeah, so to really appreciate why someone would invent this drug in the first place, you have to look at the terrifying alternatives they were working with before 1958.
Right, because high blood pressure wasn't a new problem.
Exactly. But if you had dangerous high blood pressure back then, the primary tools doctors had at their disposal were called mercurial diuretics.
And, just to be very clear for everyone, that involves actual mercury, like the highly toxic heavy metal.
Which is horrifying by modern standards. I mean, these treatments did force the body to excrete fluid, which lowered blood pressure. But they required painful injections and carried a very real, very terrifying risk of heavy metal poisoning.
Treating the disease could literally kill your kidneys.
Yeah, it was grim.
But that sounds like a really desperate situation, which makes the accidental discovery in 1949 make a lot of sense. The sources detail a researcher named William Schwartz.
Right, the antibiotic guy.
Yeah, he was working with a standard antibiotic, sulfanilamide, and he noticed a bizarre side effect in his patients. The antibiotic was causing a mild diuretic effect, meaning, it made his patients urinate more.
But there's a catch.
A huge catch. It also caused their blood to become highly acidic, throwing their whole internal chemistry off. They got metabolic acidosis.
But that side effect, annoying as it was, became the spark. Researchers immediately wondered, well, could we isolate that mild diuretic effect to replace those toxic mercury injections?
Oh, so they were actively looking for a silver lining.
Exactly. That curiosity led to the first attempt at a drug called acetazolamide. It functioned by altering the body's acid-base balance to force urination.
But the body is incredibly smart. From what I read, that drug basically outsmarted itself.
It did. It changed the blood chemistry so drastically that the body reacted defensively. After just a few days of taking it, the patient's system compensated for the acid imbalance.
It just adapted to it.
Yeah, which completely neutralized the diuretic effect. The drug essentially just turned itself off.
Wow. Imagine the frustration of finally finding a safe alternative to mercury, only to watch it just stop working by day 3.
It had to be maddening.
But that failure set the stage for a massive breakthrough at the pharmaceutical company Merck. 3 scientists, Sprague, Baer, and Bayer, they decided to tinker with the chemical structure of that failed drug.
They took the base molecule and simply added a single chlorine atom to the benzothiadiazine ring.
Just one atom.
What's fascinating here is that a slight chemical tweak birthed the entire modern era of managing blood pressure outside a hospital.
That is wild.
That team at Merck proved this newly synthesized drug, which they called chlorothiazide, caused robust sodium excretion, but through a completely different pathway than the failed drug.
So it bypassed the whole acid-base problem entirely.
Exactly. No more acidosis.
And they marketed it as Diurol in 1958. Suddenly, you didn't need to go to a clinic to get injected with heavy metals. You could just take a safe pill at home.
And then a year later, in 1959, they developed an even more potent version called hydrochlorothiazide?
HCTZ, which still absolutely dominates global prescriptions today.
It does. It was a complete revolution in outpatient care. I mean, before 1958, severe hypertension often meant hospitalization. After 1958, it just became a manageable chronic condition.
That shift from a hospital bed to a home medicine cabinet is incredible. But reading through the pharmacology notes for this deep dive, I realized I had a massive misconception about what this daily pill actually does.
You mean the whole water pill thing?
Yes. The term water pill does a lot of heavy lifting in popular culture.
And honestly, it is incredibly misleading when we talk about thiazides as a first-line defense for high blood pressure.
So to help you visualize why it's misleading, I want you to imagine the kidney's nephron, which is the microscopic filtering unit, as a massive factory assembly line that processes sodium.
I like this analogy.
Thanks. So the kidney filters your blood, and then this factory line has to reabsorb the vital stuff, like sodium, back into the body so you don't just lose it all in your urine.
And the scale of that reabsorption is massive. The first station on your factory line is the proximal tubule.
Right.
Think of this as a fleet of front-end loaders. This station does the heavy lifting, aggressively scooping up and reabsorbing about 65% of all the filtered sodium.
Then you move down the line to a middle station called the loop of Henle, handling another 25%. If you've ever heard of powerful loop diuretics, like furosemide, this is where they work.
Yeah, they shut down a huge chunk of the assembly line.
Right, causing a massive flood of fluid to leave the body.
But thiazides skip those heavy lifting stations entirely. They bypass the front-end loaders and travel all the way down to the very end of the line to a fine-tuning station called the distal convoluted tubule, or DCT.
And this final station is basically just one guy with a pair of tweezers.
Yeah.
It only handles about 5 to 10% of the sodium. Thiazides specifically bind to and block the exact transport protein that this final worker uses. It's called the NCC.
So that last little bit of sodium, and the water that naturally follows it, gets excreted.
But because it is only blocking that tiny final percentage, thiazides are surprisingly weak diuretics compared to the drugs that work further up the line.
Which is a huge shock to medical students. You naturally assume that if a drug is the first-line treatment for 1 billion people with high blood pressure, it must be an absolute sledgehammer of a medication.
Right. But it's actually the mildest option on the table.
If a doctor simply wants to remove a dangerous buildup of fluid from a patient with heart failure, they reach for those powerful loop diuretics. Thiazides serve a different purpose entirely.
But wait, this brings up a massive gap in the logic.
Oh, the volume problem.
Yeah, if it's a remarkably weak diuretic and it only removes a little bit of fluid, well, the body's survival mechanisms like the RAAS system, they're going to notice that loss, right?
Oh, absolutely. The kidneys will eventually detect the drop in fluid volume and trigger hormones to replace it.
So if the fluid eventually comes back, why does the blood pressure stay low?
That is the million-dollar question, and answering it required a massive shift in how pharmacology is taught. In the first few days of taking a thiazide, your blood pressure drops purely because your plasma volume drops.
Acute volume depletion.
Right. You lose sodium, you lose water, the volume of liquid in your blood vessels goes down, so the pressure against the walls goes down.
It makes total physical sense.
But if you measure that same patient's blood volume several weeks later, it has largely returned to baseline. The body compensated.
Right.
Yet, miraculously, the blood pressure remains lowered.
Here's where it gets really interesting because the drug's very identity changes over time.
It's just from being a diuretic to acting as a chronic vasodilator.
Which is crazy.
It is. Researchers realize that the durable, long-term benefit of a thiazide isn't about urination at all. Over time, the drug alters calcium and potassium channels within the smooth muscle of your blood vessels,
Causing those vessels to chronically relax and widen.
Exactly. It reduces the overall peripheral vascular resistance in your circulatory system.
So you take a water pill for a decade, and it's not actually functioning as a water pill anymore. It's just chronically relaxing your blood vessels.
Pretty much.
But, I mean, changing the body's chemistry like that cannot happen in a vacuum.
Ugh.
If you are blocking sodium channels in the kidney and relaxing blood vessels everywhere else, you are bound to throw other things out of balance.
Oh, you are tampering with a highly calibrated system. Thiazides produce a very specific signature cluster of metabolic side effects.
The domino effect.
Right. It starts the moment that final worker on the assembly line gets blocked.
So let's trace those dominoes for the listener. If the kidney is panicking because that final station dropped the ball on sodium, how does the body try to compensate?
It tries to make a desperate trade. The unabsorbed sodium washes further down into the collecting duct.
Okay.
The cells down there panic, and they frantically try to pull that sodium back in to save it. But to do so, they have to push something else out. So they dump potassium and hydrogen ions into the urine in exchange.
Meaning you end up peeing out your potassium stores.
Yes, leading to hypokalemia. That explains the fatigue and muscle cramps patients sometimes report.
But what about the other waste the kidney is trying to filter?
That leads to the second domino, high uric acid, or hyperuricemia. Upstream, in the heavy lifting section, the drug actually competes with uric acid for the same transport pathways into the urine.
And the drug wins the race.
The drug wins. This means the uric acid gets trapped in the blood, which can trigger incredibly painful gout attacks in susceptible patients.
Oh, man. Then there is the impact on blood sugar and cholesterol.
Right, hyperglycemia and hyperlipidemia.
Thiazides can actually worsen insulin resistance and cause modest bumps in your bad cholesterol, though the sources note that usually levels out over long-term use.
Still, it is a significant consideration when a doctor is treating a diabetic patient.
Okay, so far, this sounds like a cascade of terrible side effects. But then there is this highly counterintuitive twist regarding calcium.
Oh, yes. Hypercalcemia.
You would naturally assume any diuretic would wash calcium out of the body, potentially causing kidney stones. But thiazides do the exact opposite.
They actually increase calcium reabsorption. By altering the sodium balance inside the kidney cells, they trigger a mechanism that pulls calcium out of the urine and back into the bloodstream.
Which means instead of causing kidney stones, they actually prevent them.
Exactly.
And they help keep calcium in the bounds, which is a fantastic accidental bonus for older patients dealing with osteoporosis.
It really is. And we know this complex physiological footprint is undeniably accurate because of a natural experiment in human genetics.
Oh, right, Gittleman syndrome.
Yes. It's a rare condition where patients are born with a genetic mutation in the exact same transport protein, the SLC12A3 gene that thiazides target.
So people with Gittleman syndrome essentially live their entire lives in a state of permanent natural thiazide therapy.
Exactly. They display chronic low potassium, low urinary calcium, and mildly low blood pressure, proving the pharmacology is completely sound.
Okay, but I have to push back here, though.
Go for it.
I'm listening to this metabolic domino effect. Low potassium, gout flare-ups, insulin resistance, higher cholesterol, and I'm thinking, isn't the cure worse than the disease?
It sounds bad.
Yeah. How on earth did doctors confidently prescribe a drug that causes this much chemical chaos?
It is a completely valid question. On paper, it sounds like a biochemical disaster. But the answer comes down to hard clinical evidence. When we run massive trials in the real world, the data tells a completely different story about preventing catastrophic cardiovascular events.
So let's look at that evidence. The sources highlighted a few heavyweight trials, starting with the 1991 SHP trial.
The StudyGuide Hypertension in the elderly program, that was a landmark study. They focused on older patients who had isolated systolic hypertension, meaning only their top blood pressure number was elevated. Historically, doctors used to write that off as just a normal, harmless part of aging.
But the researchers gave these patients a very low dose of a cheap, thiazide-like drug called chlorthalidone,
And it cut their stroke risk by a massive 1/3.
treating a condition doctors used to ignore with a cheap generic drug. And it worked that well. That proved irrefutably that lowering that number saves lives.
But the true defining moment for this drug class happened a bit later, in 2002, with the ALHAT trial. The scale of this study was staggering.
Over 33,000 patients. And the drama of this trial is fascinating. They took this cheap, old, generic drug, chlorthalidone again, and they pitted it directly against the newest, flashiest, highly expensive blood pressure medications on the market.
Amlodipine, lisinopril, doxazosin.
Right. That is a massive gamble for the pharmaceutical industry.
Well, the pharmaceutical companies assumed they would easily win. Their newer, expensive drugs didn't have that messy metabolic footprint we just discussed. They believed cleaner chemistry would automatically equal better real-world results.
But the cheap generic matched or beat the expensive drugs across the board.
It was notably better at preventing heart failure.
Yeah. In fact, doxazosin, one of the fancy new drugs in the trial, had to be stopped entirely.
That was a huge shock.
Because the patients taking it were experiencing significantly higher rates of heart failure compared to the people taking the pennies-a-day generic.
It remains the ultimate cautionary tale in evidence-based medicine. Never assume a newer, more expensive drug class is automatically superior just because the mechanism looks cleaner on paper. ALHAT cemented thiazides as the undisputed first-line therapy in global guidelines for years.
Now, you used the phrase thiazide-like a moment ago when mentioning the drug chlorthalidone. We should probably clarify that structural nuance for the listeners.
Good catch. So the original drugs from the 1950s, like hydrochlorothiazide, have a specific double-ring chemical structure, a benzothiazine ring.
Okay.
Newer iterations like chlorthalidone or indapamide, they look slightly different under a microscope. They lack that original ring. But practically speaking, they hit the exact same target protein on the assembly line and produce the exact same physiological effect.
Which sets up a decades-long debate in the medical community between those two specific drugs, chlorthalidone versus hydrochlorothiazide, or HCTZ.
Oh, it was a fierce debate.
For years, experts argued the thiazide like chlorthalidone was theoretically far superior because it stays active in the body for an incredibly long time, up to 60 hours.
Compared to just, maybe 6 to 15 hours for the original drug,
Right.
the logic was perfectly sound. A longer-acting drug should provide smoother, uninterrupted 24-hour blood pressure coverage, preventing dangerous spikes in pressure overnight. Many prominent cardiologists champion chlorthalidone based on this theory.
But then comes the 2022 plot twist.
Right.
The Diuretic Comparison Project, the DCP.
Yes. They finally tested them head-to-head in over 13,000 patients to settle the debate once and for all.
And the result was a dead tie.
Absolutely zero significant difference in cardiovascular outcomes between the two drugs.
Decades of fierce pharmacological debate about half-lives and chemical rings were completely upended by the pragmatic reality of the clinical trial.
Which perfectly mirrors how the official medical guidelines have evolved. Early guidelines, like JNC7, declared thiazides the absolute, undisputed champion of blood pressure drugs.
But newer guidelines, like JNC8, have softened that stance, putting them on equal footing with other major drug classes.
If we connect this to the bigger picture, the medical community finally realized that getting the blood pressure down is the critical factor for preventing strokes and heart attacks, regardless of which specific tool you pull from the toolbox to achieve it.
Okay, but even with those stellar trial results, these drugs aren't magic. There are real-world hazards for the people taking them every day.
Especially since the primary demographic for this medication is older adults. Older adults are uniquely vulnerable to its dangers. One of the most severe risks is thiazide-induced hyponatremia, which is dangerously low blood sodium.
That sounds bad.
It is. It can happen surprisingly fast, sometimes within just a couple of weeks of starting the medication, and it disproportionately affects thin, elderly women. It is a life-threatening complication that doctors really have to monitor closely.
There is also a hard biological limit on when you can even use the drug based on a patient's kidney health.
Yeah, if a patient's kidney function declines significantly specifically, if their filtration rate, or GFR, drops below 30 thiazides, essentially stop working.
Because the factory assembly line is too broken for that final fine-tuning station to even matter.
Exactly. At that point, doctors are forced to abandon thiazides and switch to those aggressive loop diuretics to manage fluid buildup.
We also have to highlight two major drug interactions from the sources. The first involves something most of us have in our bathroom cabinet right now, standard NSAID painkillers, like ibuprofen.
Mixing NSAIDs with thiazides is a massive problem. The painkiller promotes aggressive sodium retention in the body, which essentially acts as a direct counterforce.
So it blunts or entirely ruins the blood pressure-lowering effect of the thiazide.
Exactly. And the second major interaction involves lithium, a common medication used for psychiatric conditions.
Right, because thiazides drastically reduce the kidney's ability to clear lithium from the bloodstream.
Which is very dangerous. If you start a patient on a thiazide while they are taking lithium, you can rapidly push their blood levels into a highly toxic range.
Okay, before we wrap up, I have to bring up the most bizarre pop culture footnote I found in the sources.
Oh, the sports ban?
Yes. Did you know that these mundane blood pressure pills are strictly banned by the World Anti-Doping Agency, by WADA?
It seems completely absurd. You wouldn't think a drug prescribed to a grandfather for his heart health would be classified as a performance-enhancing substance.
But professional athletes abuse them for two very specific reasons. First, because they force fluid out of the body. Athletes in weight class sports like wrestling or mixed martial arts, they use them to rapidly and illegally drop water weight right before a weigh-in.
The second reason is far more insidious, though.
Yeah.
Because these drugs drastically increase urine output, they heavily dilute the urine itself. This dilution acts as a chemical masking agent.
So it artificially lowers the concentration of anabolic steroids or other banned substances to help an athlete pass a drug test.
Exactly.
So what does this all mean? We have a drug that is at once a life-saving essential medicine preventing millions of strokes for pennies a day, and simultaneously a chemical masking agent banned at the Olympics.
It is a drug of incredible duality.
It truly is.
It serves as a perfect case study for how a seemingly simple mechanism translates into staggering complexity once introduced into the human body.
So let's bring this all together for you, our listener. We started with a toxic mercury injection and ended up with a daily pill that bypasses the heavy lifting in your kidneys to block just a tiny fraction of sodium.
And while it starts as a mild diuretic, its true superpower is chronic vasodilation, relaxing your blood vessels over the long term.
And it leaves a massive metabolic footprint, dropping your potassium, risking gout, but bizarrely protecting you from kidney stones by pulling calcium back into your blood.
It demands decent kidney function to work and requires careful monitoring alongside common painkillers. Yet, despite those quirks, a cheap generic pill from the 1950s repeatedly fought the newest, most expensive modern drugs to a standstill in massive global trials.
This raises an important question about how we view progress in medicine.
It challenges the fundamental assumption that newer and more expensive automatically means better, proving that tried and true generics still hold immense value in modern healthcare.
And it leaves me with one final provocative thought for you to ponder. Think back to that 1950s origin story. This entire class of drugs, this miracle that has saved countless millions of lives, it only exists because scientists were trying to fix the annoying side effects of an earlier failed antibiotic experiment.
Yep.
It really makes you wonder, how many failed drugs or annoying chemical side effects sitting forgotten in pharmaceutical databases right now hold the accidental clues to the blockbuster, life-saving cures of the 2070s.
I mean, the next great medical miracle might be hiding in plain sight, just waiting for someone to add a single molecule.
It is a powerful reminder that in science, there are no true dead ends, only detours. Thank you for joining us on this deep dive into the sources. Keep asking questions, keep looking past the surface of those everyday rituals, and stay insanely curious.